Boa tarde a todos. Nós vamos dar início a esta sessão de casos clínicos, que é uma parceria entre o Departamento de Ergometria, a Sociedade Americana de Medicina Nuclear. Esta sessão está sendo com tradução simultânea. Quem desejar pode pegar o seu rádio ali na saída à direita. Eu sou ROMEU MENEGHELO, de São Paulo, do Instituto Dante Pazzanese de Cardiologia e do Hospital Israelita Alberto Einstein. Ao meu lado, um dos expoentes da cardiologia nuclear do Brasil.
Obrigado, doutor ROMEU. Eu sou RONALDO de Souza Leão Lima, sou professor associado da UFRJ e sou diretor de Medicina Nuclear do DASA e da Fonte Imagem. Eu queria, mais do que nunca, prestar uma homenagem ao meu amigo João Vítola, por esse sensacional congresso, um evento ímpar, e ele ainda me deu o presente de apresentar uma sessão com um ícone da cardiologia do Brasil, que é o professor ROMEU MENEGHELO. Mas vamos passar para o primeiro caso.
Pois não, vamos chamar então o Dr. GABRIEL GROSSMAN, que é doutor em cardiologia pela Universidade Federal do Rio Grande do Sul, fellow em medicina nuclear na Emory University, nos Estados Unidos, presidente eleito do Derc 2020-2021, membro do Board of Directors da American Society of Nuclear Cardiology, médico da Clínica Cardionuclear Instituto de Cardiologia Porto Alegre e chefe do Serviço de Medicina Nuclear do Hospital Moinhos de Vento, em Porto Alegre. E nosso amigo.
Que é o principal. O principal item do currículo é esse. Bom, eu faço as minhas palavras, as do Ronaldo. Eu acho que esse congresso realmente está excelente e eu gostaria de agradecer o convite para participar como membro da comissão e também como apresentador e moderador. Realmente, muito obrigado. Bom, são 4 casos, né? Eu acho que o meu caso é um caso do dia a dia que eu escolhi. Quem trabalha com métodos de imagem vai se sentir muito confortável em avaliar esse caso, porque é o que a gente faz rotineiramente e mostra como, no caso, um estudo funcional, a cintilografia pode ajudar. Eu não tenho nenhum conflito de interesse. Então, vamos já direto para o caso. É um homem de 57 anos, hipertenso e dislipidêmico, em uso de atenolol, diurético, amlodipina, aspirina e estatina, então estava bem medicado, e ele teve uma dor intensa no peito jogando futebol. Depois, na anamnese do médico que o avaliou pela primeira vez, ele referiu que tinha alguns episódios de dor no peito com alta carga de exercício, né? Ele, no exame físico, não demonstrava nenhuma particularidade e ele fez um teste ergométrico que tinha uma alteração, um infradesnivelamento do ST de 2 milímetros. Se nós formos olhar a tabela de Diamond and Forrester, que ela é muito utilizada, nós sabemos que a tabela de Diamond and Forrester superestima a probabilidade de pré-teste, mas ela ainda é muito utilizada na avaliação dos pacientes. Nós percebemos que um homem de 57 anos, com dor típica, como é o caso desse senhor, ele apresenta alta probabilidade pré-teste de cardiopatia isquêmica. Então, o diagnóstico clínico já está feito. Esse paciente tem uma alta chance de ter cardiopatia isquêmica, certo? Então, qual seria o próximo passo nesse caso? Um cateterismo, já direto, um ecoestresse, uma ressonância magnética, uma cintilografia miocárdica, um SPECT, ou uma angiografia invasiva. Quem faria um CT, desculpa, um angiograma por CT? Quem faria o cateterismo direto? Quem faria o ecoestresse? Quem faria uma ressonância? Um SPECT? Bastante gente até. E um CT? Bom, na verdade...
Tratar não vale, né?
Hã?
Tratar não vale, não?
Não, não, calma. Ele já vinha sendo tratado por outras causas, mas aqui é a questão... Bom, a gente viu que tem várias opiniões, e, na verdade, isso reflete exatamente a prática, porque não tem uma resposta certa para esse caso. A gente pode optar por diversas formas para avaliar. Se nós formos avaliar esse paciente com alta probabilidade de pré-teste, com capacidade de fazer exercício e eletrocardiograma interpretável, a cintilografia miocárdica é apropriada. Então, quem disse que a cintilografia deveria ser feita está de acordo com essas diretrizes. O estresse eco também, a ressonância também. A tomografia coronária, talvez, maybe, né, mas não está errado fazer. E quem gostaria de fazer um cateterismo direto, também está certo. Então, não tem uma resposta certa. Por isso, qual é o melhor método? Na verdade, não tem resposta. Tem várias coisas que poderiam ser feitas nesse caso. Na verdade, quando nós estamos avaliando funcionalmente um paciente com alto risco, como esse caso, que já tem um diagnóstico clínico feito, nós não estamos apenas usando o método funcional para corroborar nossa opinião clínica, mas também já usamos esse método para estratificar o risco do paciente. E nós sabemos que a estratificação do risco baseada num método de estresse com imagem tem uma indicação classe 1, nível de evidência B, para avaliação de pacientes com alto risco. E nas diretrizes brasileiras de cardiopatia isquêmica estável, os colegas que fizeram essa diretriz consideraram, então, eu não estou... está aqui? Não está vindo aqui o... consideraram que um paciente com capacidade boa para fazer exercício, com alta probabilidade de pré-teste de cardiopatia isquêmica e eletrointerpretável, tem indicação classe 2A, não é indicação classe 1, como as diretrizes europeias, e nem apropriado como as sociedades americanas consideraram. Mas, enfim, classe 2A é sinal de que o exame pode ser bem indicado. Bom, o que esse paciente fez? Ele fez uma cintilografia miocárdica. Ele foi submetido a um protocolo de Bruce, 5 minutos e 47 segundos, teve dispneia, mas não teve dor torácica, atingiu 87% da frequência cardíaca máxima prevista. Esse é o eletro inicial. Não sei se alguém quer fazer algum comentário. Estou fazendo interativo aqui, porque me foi dito que poderia ser feito assim. Hein, Ronaldo, Romeu, alguma...
É um eletrointerpretável, né? Talvez um low transition, V3, V4, mas isso pode ser posicional, mas eu acho que é um eletrointerpretável.
Eventualmente uma redução de forças septais.
Bom, esse é o pico do esforço.
Claramente positivo. Né?
Claramente
inclusive
positivo.
Com supra de AVR, com alterações de D2, D3, AVF, D1...
Tem supra em AVR.
Definitivamente positivo. Com que carga, Gabriel? 5 minutos.
Sim,
né?
menos de 6 minutos. E aqui, já com uma recuperação quase de 5 minutos, persistia ainda com ST, descendente. Bom...
Teve mais alguma alteração,
não.
Gabriel? Caiu pressão?
Não caiu pressão, não teve dor no peito. E essa aqui é a cintilografia miocárdica. A cintilografia miocárdica mostrava, então, uma extensa área de isquemia na parede inferior, no septo, no ápice, no segmento anteroseptal, anteroapical, septoapical, enfim, uma extensa área de isquemia de pelo menos 2 territórios coronarianos. A quantificação da isquemia, não sei se dá para ver aqui, mas deu mais de 20% de área isquêmica, né? O mapa polar coincidente com o que a gente vê na análise visual, e uma queda da fração de ejeção de 54% para 43%, com hipocinesia daqueles segmentos todos hipoperfundidos. Certo? Então, qual o próximo passo? Cateterismo ou tratamento clínico? Alguém vota no tratamento clínico? Tem um médico, um colega que votou no tratamento clínico. Tá bem. Bom, o que nós sabemos até hoje, à luz do conhecimento atual? Isso, já desde aquele estudo clássico, que vocês já devem ter visto esse slide inúmeras vezes, à medida do grupo do Sidersteiner, do Dr. Hakamovich e Berman, à medida que aumenta a extensão da isquemia, existe uma tendência ao paciente se beneficiar mais da revascularização, com ponto de corte em torno de 10%. E essa é a base, esse é o racional de todos os estudos que surgiram depois, o subestudo nuclear do Courage, o subestudo do Bari 2D e agora o isquemia, que vai ser apresentado em novembro no American Heart. Bom, baseado em todos esses estudos que eu citei, que se baseiam no racional dessa primeira figura, as diretrizes europeias de 2018, do ESC, o que elas nos corroboram? Que, mesmo se o paciente não tenha sintomas, que não é o caso, esse paciente tem sintomas, independente da anatomia desse paciente, se esse paciente tem uma área isquêmica de mais do que 10%, ele tem uma indicação classe 1, nível de evidência B, de fazer revascularização, de ser revascularizado. Então, a quantificação da isquemia, até o momento, com toda a base científica que nós temos, ela pode definir conduta sim. E por isso que, mesmo que a gente tenha o diagnóstico clínico de cardiopatia isquêmica nesse caso, ou pelo menos de uma alta probabilidade de pré-teste, o exame funcional, a cintilografia miocárdica, nos ajudou a definir conduta. Porque se esse paciente tem uma área isquêmica maior do que 10%, ele vai se beneficiar da revascularização, o que é o caso desse paciente. Então, aqui, o cateterismo, que nós vamos ver que tem uma oclusão da CX que enche por colateral, né? Ele tem esse próximo aqui mostra uma lesão grave na DA proximal também. E a coronária direita, com uma lesão importante no terço proximal e também uma lesão grave na descendente posterior. Perfeito. Alguma dúvida até aqui? Eu disse que era um caso bem simples, mas que é o nosso dia a dia. Bom, esse paciente, ele fez revascularização cirúrgica, ele colocou uma mamária para DA, 2 safenas para CX e para descendente posterior. Por que eu trouxe esse caso? Primeiro, porque se trata de um caso do nosso dia a dia. Ele é um caso simples, mas, como se diz em inglês, straightforward. Não há muita dúvida. Primeira coisa que eu gostaria de ressaltar nesse caso. O teste funcional, quando nós estamos realizando esse teste para um paciente que já tem alta probabilidade de ter cardiopatia isquêmica, como é o caso, o teste funcional ele não só confirma o diagnóstico, mas ele estratifica o risco. E é isso que nós queremos nesse caso. Nós queremos estratificar o risco desse paciente. E esse paciente teve o seu risco estratificado no momento que nós conseguimos quantificar a área isquêmica, definimos outros marcadores de alto risco, queda da fração de ejeção, né, dilatação da cavidade. Então, ele ajuda não só a confirmar o diagnóstico, que já é clínico por natureza, mas também a definir conduta. E isso é o que nós buscamos um exame, certo? Esse gatilho para definição de conduta. Nós não temos uma resposta apenas, como eu mostrei nos critérios de propriedade, de estar apropriado ou não. Existem vários testes que podem ser utilizados nesse caso. Pode ser uma cintilografia miocárdica, outro teste funcional, um ecoestresse, uma ressonância. Eu, particularmente, prefiro, quando o paciente pode fazer exercício, um teste funcional em que o paciente possa fazer exercício como forma de estresse. A ressonância, infelizmente, nesse caso, desde o meu ponto de vista, mesmo que seja apropriada a indicação, o paciente não se beneficiaria em relação ao ecoestresse com exercício ou a cintilografia miocárdica, porque nós conseguimos, colocando o paciente no exercício, avaliar a capacidade funcional, resposta hemodinâmica, presença de arritmias. Então, nesse caso, eu acho que seria um ecoestresse ou uma cintilografia miocárdica, que é o que foi feito especificamente para esse paciente, definindo, então, confirmando o diagnóstico e definindo a conduta. O paciente está muito bem e assintomático nesse momento. Obrigado.
Gabriel, só aproveitando esse último minuto, fazendo meio o papel do advogado do diabo, mas algumas pessoas tinham sugerido no início do exame uma angiotomografia de coronária. Nesse caso, a angiotomografia de coronária também teria estratificado esse doente para a conduta, né?
Não, eu acho que a tomografia de coronárias, ela é um bom exame, mas eu não acho que ela se aplique tão bem para pacientes com alta probabilidade, certo? Com alta probabilidade nós vamos ver lesões, um paciente perto dos 60 anos, nós vamos ficar em dúvida da repercussão dessas lesões. Eu gosto muito da tomografia de coronárias para usar o valor preditivo negativo, para excluir doença. No entanto, pode ser utilizada, se a gente vê a anatomia muito comprometida, esse paciente faria um cateterismo de qualquer maneira.
Perfeito.
Obrigado, Gabriel.
Então, nós vamos passar agora para o segundo caso. Eu convido o professor Lucas Gutierrez. Ele é chairman do Departamento de Cardiologia Nuclear do Instituto Diagnóstico e Ressonância em Mendonça, membro do Penta Cardiovascular Medicine e do Programa de Prevenção Cardiovascular em Chakras do Medical Center.
Obrigado. Unfortunately, my Portuguese is very bad, so apologize. I will try to make the presentation in English. I hope you can understand me. First of all, I want to thank especially the organization and Dr. Vitula, and especially Dr. Ojeda for the kind invitation. For me, it's a pleasure to be here with friends. This is an everyday case from my lab. Unfortunately, also, I don't prepare the case with an interaction, but we can try it. We are going to run through the case. I have no conflict of interest. This is a male of 50 years old with no history of coronary artery disease, with smoker, hyperlipidemia, and hypertension. His treatment with losartan. The history of the patient was a sedentary style of life. He went to his doctor's office and for a checkup, and in the checkup he refers sometimes shortness of breath, and he wanted to make and try to improve his quality of life. The patient performed an abnormal stress test, so the referring physician asked for a nuclear test. I don't know if you agree with that. This is our result for the stress test. He performed a very good quality of exercise, more than 10 METs. He don't achieve the maximal heart rate, predicted heart rate, but 83% is good. 200 watts, and he performed asymptomatic. Here's the ACG of the rest. Somebody wanted to make a comment about this? It's a pretty normal.
Yeah. Normal. Yeah.
Right? So this is the stressed ACG. Right. Well, we agree that this is barely confusion. This is the average, and we can see the leads in inferior and lateral wall is more compromised, and also the Duke treadmill score is in high risk. So let's move forward for the perfusion imaging. These are the SPECT perfusion imaging with the rest stress. You can appreciate a very homogeneous distribution of the radio tracer. Also, we perform routinely prone imaging for minimize the attenuation artifacts. Also, we perform, of course, the gating imaging. So in the gating imaging, we can appreciate is a very good motion, thickening, ejection fraction actually is going up. What would you think about this? Don't answer yet. There's also the quantitative polar maps. We have no extension of perfusion defects, so it's pretty normal also. This is the gating imaging. Wall motion abnormalities and is there. There's also a good motion and thickening. In your left side is going to be the stress ejection fraction, and the right side is going to be the rest ejection fraction. Also, the onset of mechanical synchronicity is quite good. It's really normal. It's another parameter of function. So we have an intermediate pretest probability for CAD, because shortness of breath, we can maybe think of an equivalent of an angina symptoms. We have a high-risk treadmill Duke score with a normal perfusion spec, normal function, and a normal phase analysis. So the question mark, what would you do in this case?
Dr. Gutierrez, let me ask you one question. Do you have the TID index of the patient?
Yes, but it was normal.
Normal?
Yes, below 1.2. No, no lung uptake. We have an echo. It may have a little bit of mild hypertrophy, but it's pretty normal. Try to get faster. Some practical points. In the literature, Yokota, I recommend this lecture, it's very good. Prevalence, location, and extent of significant coronary artery in patient with normal myocardial perfusion imaging. So he asked, can we improve, particularly to avoid the false negative results in MPI? An MPI patient with left main and multivessel disease can result in false negative result because of reliance of the reference area with a normal blood flow 25 area with decreased perfusion. Here are all the asking questions that you will do into me. Transient ischemic dilation, drop off the EF, increased lung uptake, wall motion, thickening abnormalities. But quick question this. Calcium cost may be improved. So in my place, we don't have a CT dedicated. We try to work with what we use, and we perform a conventional CT scan with non-gated, 16 detectors, and 2.5 slices. This is what we found. So we have evidence of coronary calcification in not only the coronary territory, also in the aorta, also in the aortic valve. So this is changing our patients. We have more than 100 ICATON scored, only in the coronary quantification, but we have severe calcification in other parts of the vasculature. So, what's next? We saw these slides before, and calcium score findings are independent predictors, also in normal SPECT. So this patient has a high risk in terms of calcium scoring. This work from Nakanishi, from the group of the CEDARs, and the participation also with Dr. Shaw, was very interesting. More than 20,000 patients with SPECT scan, they classified about who performed normal scans with cardiac catheterization. And they found these indicators: intermediate, high intermediate pretest probability, high Duke Trexamil score, more than 0 of TPD, dosal perfusion deficit, EF changes, and chest symptoms. And also, when they analyze the patients who have high risk about the anatomy, they found this: more than 23% were 0 or below 3 on the Summit stress score. Very interesting. This is from my colleague from Argentina, Dr. Camiletti and Dr. Arrest from La Plata. They published this article in 2016 in the Journal of the Argentine Federation of Cardiology about a screening of 200 patients with calcium score from 0. And it's interesting what they found. 15% of plaque, coronary plaques, and 1.5% from severe obstructions. So we cath the patient. This is what we saw. RCA, proximal, critical. Left main LAD, where the calcium were, for me, it's pretty good flow over there. And the left circumflex, also with severe stenosis, and the trifurcation is a complex lesion. So we have a high-risk anatomy, severe RCA, left circumflex, and a lot of calcium in the left main and in LAD, because we saw it in the scan. What's next? What do you think?
In the morning, Dr. Mazzoli did a superb presentation showing myocardial blood flow with CCT camera. And when you present your data, I think I will love to see the myocardial blood flow of this patient before the results of the CAT.
Right, I agree. Unfortunately, I don't have that. This review from last year from the Journal of Nuclear Cardiology, reconciling discordant myocardial perfusion imaging and coronary angiography. Here, the authors demonstrated high risk with an event rate of combined of myocardial infarction and mortality, also in 2 vessels disease. So the recommendations was revascularize the patient. This is the RCA, previously and post-revascularization. This is the left circumflex. Post-revascularization is a complex procedure because of trifurcation. So we can resume our patient with pretest of probability of intermediate risk, nuclear stress test with high Duke treadmill score. This is important for our functional analysis later. The calcium scoring for more than 700, and cardiac cath with severe anatomy. We call it balanced ischemia. And the decision was to revascularize the patient, optimal make on treatment, quit smoking, and exercise. So take-home tips. First, recognizing patients at high risk for MACE, despite normal perfusion, remains a difficult challenge. High intermediate, high pretest probability found evidence to be associated with obstructive coronary artery disease and high-risk coronary disease in patients with normal spec MPI. Use the available technology that we have in our countries. We need to do that. We must do and work with our available technology. And combining functional imaging with SPECT and anatomic imaging with calcium scoring, provide incremental prognostic information with regard to the degree of coronary disease. So thank you very much. I invite you to visit my province, Mendoza, in Argentina. Thank you.
Próxima apresentação de caso do Dr. PREM SOMAN. Ele completou os estudos com bolsas de estudo em cardiologia e imagem cardíaca avançada no Tufts Medical Center em Boston, Massachusetts, Estados Unidos. Na Universidade de Pittsburgh, SOMAN é professor associado de Medicina, Divisão de Cardiologia e de Ciência Clínica e Translacional. Fundador, diretor da Clínica de Amiloidose, e a sua pesquisa enfoca o uso de técnicas de imagem baseadas em radionuclídeos para investigar doenças cardíacas. É coautor de várias pesquisas originais, de editoriais, capítulos de livros, diretrizes nacionais e critérios de uso apropriado do American College of Cardiology. Presidente da American Society of Nuclear Cardiology 2017-2018. Dr. PREM.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. Thanks for the invitation. Joao, it's a great privilege to be here. I'm going to show you 2 cases very quickly, and the principle here is integrating the information from the stress test into our overall patient management. So here is a 59-year-old surgeon with mild dyslipidemia, and he had chest pain. He was on vacation with his wife and had chest pain with an argument. So this is common, right? The first 3 days are great, day 4. So I will make this case interactive and say, how many of you argue with your wife when you go on vacation? Yeah. So he lands up in the emergency department where he has, for her, but we are now talking about him. So he has a negative ECG in the emergency department, a negative high sensitivity troponin, but they found that his blood pressure was elevated just a little bit, and he was admitted for observation. Now, he happened to have a coronary CTA, and I'm not a CTA expert, but you can see the mid-LAD territory, what looks like a significant lesion. So this is a young man, no other symptoms, has risk factors, but not known to have coronary artery disease. And he came to Pittsburgh with this report of a CT-FFR, which shows a value of 0.5, so very, very highly significant. And so he comes to our department with all of these results, and he was told that he needs coronary angiography and possibly a stent. But this gentleman had absolutely no symptoms. He would go running every day, play soccer, did not argue with his wife anymore, so he had no more chest pain. He was put on aspirin and statin, and his blood pressure was normal. And so we decided to get some functional information. And here is the perfusion scan. This is a D-SPECT camera. It's one of the new CZT crystal cameras. And the top 2 images are stress supine and stress upright. And the third is rest upright. This is a very, very normal perfusion scan. And of course, the function was normal with a very good ejection fraction. So the question here is, what reflects the true physiology? Is it the CT angiogram or the SPECT, right? And we can talk about, there's no balanced ischemia here. We can talk about SPECT missing the disease. We can talk about he does have coronary artery disease. That was good. We detected that. But I haven't told you the exercise test results, and that is the important thing here. He went 12 minutes on the Bruce protocol, 13 METs, 90% age-predicted maximum heart rate, no chest pain. This is really important. No chest pain. Reason for stopping was leg pain, and he had a negative ECG. So this exercise test result gives the physician a great deal of confidence in telling the patient that, yes, you have coronary artery disease. We don't need to rush you to the cath lab. We can treat you with optimal medical therapy. And if you have recurrent symptoms, maybe we can revisit the situation later on. So very important, the exercise physiology. We know that exercise is the most true physiological stressor. It increases the rate pressure product and induces ischemia, unlike vasodilator stress, which produces flow differences, but doesn't necessarily induce ischemia. For me as a clinician, when I put a patient on the treadmill and he develops symptoms, and with the symptoms he has ST depression, and with that he has a perfusion defect, that is very powerful information that correlates the symptoms to exercise. And if he doesn't have symptoms with a lot of exercise, then you have to question, yes, he has CAD, but are his symptoms due to CAD, which is a very important determination. And we know that it is one of the most strongest prognostic parameters from this and other studies showing that if patients achieve more than 10 METs on the treadmill, then they live very long, and it's not necessary to do anything drastically. So that is my first case. Any questions on that?
Could I ask, just as a devil's advocate, Prem, what was the difference in time between the time of the CT and the time of the nuclear? And I asked this having looked at the CT. There was a lot of soft plaque. There was a little bit of, maybe even a bit of spotty calcification there as well. And I questioned if there was a great distance. Could there be some sort of change in the plaque morphology? The chest pain had settled down. And is it possible that, in fact, both results are correct and just demonstrate the evolution of the plaque over a period of time?
I didn't have my translators on, but I think I understood what you're saying.
I have learned that over the years. I can help you.
Yeah. but I think that's a very insightful question, Nathan. And you know, I use this not as a comparison between the CT scan and the nuclear study. You're absolutely right. They are telling you two different things. And it's likely that he may have had a small erosion, plaque erosion, little bit of thrombosis and microvascular ischemia that produced that symptom. But what that needs is optimal medical therapy, right? I don't think revascularizing him at that point would have changed prognosis. So it gives us, that's very, very powerful data. You know, as Leslie was presenting her data the other day, and Marcia was talking about stuff this morning, we're in a stage where our understanding of coronary artery disease is evolving, right? CT has a role, nuclear has a role, but one of the things that has really withstood the test of time is the strong prognosticator of exercise capacity. If you can get on a treadmill and do 15 minutes, you're indestructible practically, right? And we've got to figure out how that matches up with our understanding of plaque physiology. What's the connection? That even if you have plaque, if you can do good function, then that somehow protects you, and I don't know the answer to that.
How do you explain the FFRCT results?
You know, we are at that point in the evolution of FFRCT that sometimes we just don't explain it. You know, it is, we know that in the intermediate zone, FFRCT is not very reliable, right? And that meta-analysis from Cook in JAMA showed that exactly at that intermediate point where you need it the most, diagnostic accuracy is about 40%.
That's the major problem of CCT.
Right, yeah.
FR.
But it's a good test. I mean, I'm not saying that it's not a good test, but that's where other things like exercise physiology help us. Okay? The second question is very similar to what Lucas showed you, and I'm going to take a little different approach to this and talk about how we report these stress tests when you have disparate information from the ETT and the perfusion scan. So this is a 77-year-old male, smoker with atypical symptoms who underwent treadmill exercise testing. The average time on the Bruce protocol, had a completely normal hemodynamic response. He had atypical chest pain, which was not limiting. And this is very important when you assess the Duke treadmill score, but continued exercise until he stopped due to fatigue. Then he has a 2 millimeter ST segment depression in the lateral leads, beginning at moderate exercise levels and persisted for about 2 minutes, which is significant. It's a little more concerning than ST segment depressions that resolve within a minute after cessation of exercise. And his MPI was completely normal. The LV function was normal. So what do you do? So if you had to interpret these findings, if I gave you some multiple choice questions, what would be the most appropriate response? You say he needs coronary angiography. His risk of cardiac death or non-fatal MI is intermediate. His risk of cardiac death or MI is low, or the risk is indeterminate. We're not able to risk stratify due to the conflicting exercise and MPI findings. So here is where the Duke treadmill score comes in and was developed by Daniel Mark, working at Duke in the 1990s, and you all know how this is to be calculated. And the angina index, it's important to determine whether the exercise was stopped because of chest pain or it was non-limiting, and in this case it was non-limiting. And clearly this patient is at intermediate risk Duke treadmill score. And in this situation, myocardial perfusion imaging is really very useful. And I know Dr. Vitola has done some work on this. This is the classical paper from Rory Hakamovich at Circulation, and it's really very beautiful information. And on the x-axis there are patients classified based on the Duke treadmill score risk. Color-coded there in red are patients with normal myocardial perfusion, mildly abnormal myocardial perfusion, and very severely abnormal myocardial perfusion, and then is the heart event rate based on this classification. Important thing to note is that if you have an intermediate risk Duke treadmill score, a normal myocardial perfusion then reclassifies that risk to a very low risk. And by low risk, of course, we mean less than 1% per year. And as was shown in Lucas's case, if you have a high-risk Duke treadmill score, then you have to do something more. A high-risk Duke treadmill score, even in the presence of a normal perfusion scan, indicates risk of adverse events, as is shown here, and as was shown very nicely by Lucas. So I find this very useful, and because now we have data here, of course, what you have to say is that this risk of cardiac death or MI is low, and I usually put this in my report. And I will say that in this patient with an intermediate risk Duke treadmill score, the normal myocardial perfusion is predictive of a low risk of adverse events, and we have a lot of data to show this. Now, as a side, this just came up because I'm talking about the Duke treadmill score, and you know we say that in cardiology, less than 1% risk, annual risk is low. Anybody know where that came from? Why do we say that a risk of less than 1% per year is low? And this actually came from Daniel Mark, who in that paper says, since the risk of a coronary revascularization procedure, and that time we're talking about CABG, performed by a skilled physician is on the order of 1%. So the risk of treatment is 1%. Then if the risk of the patient is less than 1%, then there's no point in sending these patients for invasive therapy. And many decades later, even though the risk of bypass is now not 1%, it's much less. The risk of PCI is not 1%, it's much less, but we still use this 1% as the cutoff for low risk, and it is time to rethink this fundamental concept. Thank you very much.
Thank you.
Agora nós vamos ter o Dr. Nathan Beta, professor de cardiologia de Melbourne, na Austrália, completou sua formação na Escola de Medicina de Harvard, em Boston, e atualmente trabalha como cardiologista no Hospital Royal Melbourne.
I'm one step behind you. While you get used to my Australian accent. I've given a few talks already today, and once again I'd like to thank the organising committee and my good friend João Vitola for inviting me here to your absolutely beautiful country. And I'd also like to take the opportunity to thank the two medical students, Teresa and Gabriela, who have been looking after me so beautifully over the last couple of days as well too, and putting up with me and learning about my Australian quirks. And I get to be the last speaker, and we actually all chatted a little bit over the last few days, and we've come up with a little bit of a diversity. I want to really say how much I enjoy your country, and boy, do you guys have some fantastic swimming pools.
That's our jacuzzi.
That's the jacuzzi. It was great. I went in the jacuzzi. Wasn't that warm? So far, we've actually looked at some cases which have actually shown large amounts of ischemia or balanced ischemia. I'm going to actually do the exact opposite. And I actually just specifically was asked by João for this talk not to go back to any shelf lecture, but I literally just took a case out of the last 2 weeks before I left my home in beautiful Melbourne, Australia, which I'd love you all to come and visit. What I actually did, this was a case which was just a garden variety, and I'm going to look at the question mark about a mild amount of ischemia and how we deal with this. So let's talk about our patient. 72-year-old male, past history of hypertension, excessive alcohol, ex-smoker, cholesterol 6.0, like an average Australian patient. That's not true. Has a history of asthma as well, and has a history of paroxysmal atrial fibrillation. Importantly, the patient was on flecainide, 100 milligrams BD, and verapamil, 180 milligrams, not on a beta blocker because of the history of asthma, also on apixaban, and well controlled, so the atrial fibrillation was not causing the patient any problem. Presenting with very atypical pain that to the clinician did not sound cardiac, but importantly, wanted to rule out ischemia. Not so important to rule out coronary artery disease, but to rule out ischemia in terms of ongoing management, and particularly the ongoing use of flecainide in this patient, which could provide an increased risk in the long term. So the patient was referred to us for an exercise MIBI study. They went for 12 minutes of a bicycle protocol, achieved 100 watts off the verapamil for 24 hours, so that's quite a high workload, had a good double pressure product with the heart rate rising into 150 and the blood pressure rising from 160 over 90 up to 260 over 130. So a very hypertensive response, but off therapy. The patient had no chest pain, but the test was ceased due to fatigue. ECG showed sinus rhythm throughout with 1 millimetre of upsloping infralateral ST depression. Now, for the first 4 minutes, I've done the talking. Now I'm going to get you guys to contribute a little bit. Let me show you some images. In our department, we do all of our imaging prone as a matter of course. And in the first, third, fifth, and seventh rows, you can see here the stress imaging. And in the even rows, you see the resting images as well too. So these are the prone study. So I'll give you a second to have a little bit of a think about this. I might call on my friend João maybe to make a comment about this, if you want to give him the microphone here. I want you to focus in a little bit that the septum looks a little bit hotter, the infralateral wall looks a little bit down.
Yeah, but not...
It's nothing like the scans we've seen a little bit earlier on here, but it's not completely normal. Would you say this is normal? Would you say this is mild lateral ischemia? Which way would you go at this point, João?
A little bit hot in the septum, so this makes the lateral wall look a little bit down, but normal size cavity and no clear-cut defect. So it would pass as a normal study.
Yeah. And remembering that this patient has a history of severe hypertension as well too. And we often see in the hypertensive patients that septal defect can get worse. We have a large renal transplant unit, and in our renal patients, it's almost every single patient has an appearance like this. But it's not the normal physiology where the lateral wall is usually a little bit hotter than the septum. When we looked at this original prone image, we thought that actually, in fact, if I can get this mouse to work, don't think it is, but that's okay. We thought that the infralateral wall was a little bit further down at stress and a little bit better at rest. So we thought that there was a little bit of mild infralateral ischemia here. That was the original call. So we repeated the study again with CTAC to see if this actually helped. Usually it doesn't get rid of the septal problem, but at the end of the day, we still thought there was a little bit of reversibility here in this infralateral wall. So the question here is this going to be mild ischemia, or is this going to be a normal study with an artifact? Now, I want you guys to think about this because it's the first question I'm going to get you to vote on in a few minutes' time. So you can either agree with me and call this a mild infralateral ischemia, or you can agree with João, and he's the boss here, I guess, and call this all artifact. But have a think about this for a moment as well too. Let's look at the left ventricular function. And here you can see quite normal function at stress, normal function at rest. In fact, it's almost a supernormal scan, and the LV function is actually quite increased at around about 75% for the ejection fraction. And when we look at here in the reconstructed pictures, certainly quite normal here at stress, normal at rest. We also look at the time activity curve. I've got my pointer back, excellent. This is not this patient, but we look at the relaxation. So we look at the time activity curve during systole and during diastole. During the last presentations, I saw some beautiful work with some phase analysis. We don't do that routinely, but I'm going to take that home and actually start doing that some more. But we do look at the time activity curve. Some of my colleagues try to look at peak filling rates as well. And this is how a normal curve should look, with the appearance like this, but this particular patient looked like this, so it was a very slow relaxation. So we're thinking in this hypertensive patient that they not only have this question mark about the mild infralateral defect, but they also have diastolic dysfunction, so HFpEF as it's called as well too. So another cog that we can use in nuclear medicine or nuclear cardiology to help assist in patient management. We also have the CT images to look at. And this is a prone study, as you recall, so we do our CT prone as well too. You can see some calcium here in the LAD, but importantly, there was no calcium in the circumflex and no calcium in the right coronary artery. So we've got some calcium in the LAD, but that was not the area that was particularly concerning us on the images. So we're now all a bit squirmy. I'm looking at the crowd because for the other guys, my three colleagues here, the images were clearly normal or clearly abnormal. But this is an everyday garden case, and we have to make a decision to aid our patient management. So, what should I do? What should I say? And it's time to vote. Everybody's going to put their hand up here. Firstly, is this artifact due to hypertension, or is this artifact due to mild circumflex ischemia? Everybody vote. Who's going to call this artifact? Half the four hands go up. Who's going to disagree with João and call this mild circumflex ischemia? No, you can't disagree with me, João. Exactly half. So we've got really split down the... You could put everybody on one side, everybody on the other side. What did I do? And I want you to give you some time to think about this again too. What did I do? I called it artifact. So in fact, I actually sat there with João. But I got to tell you, this was a garden variety case, and I was umming and ahhing. I looked at the exercise test. I know the patient went for 12 minutes of my bicycle protocol. They did an excellent exercise performance, and as Prem showed us beforehand, the exercise data put this patient into the low-risk category, reduced my clinical suspicion. It wasn't like Lucas's case with those marked ST changes, which may have raised my suspicion a little bit. But I used that exercise data to downgrade it. I called it artifact. Am I right? I don't know. Now, what should I do? With this in mind, some of you who called it artifact will probably do nothing, but those of you who actually did call this ischemia now have to decide. Should we do a cath or a CTCA, or do we treat the patients medically? Time to vote. And those of you who actually voted for artifact, you're allowed to show your hands as well too. Who's going to stop and just do medical therapy? Hands up. Who wants to do another test, either a cath or a CTCA? Nobody? A few people, great. So those people who put their hands up, who would do a cath? Who do a CTCA? So in fact, we've got nobody doing a cath. So if the truth of the matter is, as shown beautifully by my colleagues from that Hachamovich data, and the ischemia trial is going to look at this further, okay, probably not so much for this patient, but certainly Hachamovich data is done, we can actually use this trial. Every single person in this room has actually said, because at most it's mild ischemia, we're not going to cath the patient. We've used this data to make clinical management decisions. And those of you that did want to do some sort of testing, you're doing CTCA to reassure you. And I suspect that if the CTCA was strongly positive, you may have considered to do the cath at that stage. But you're still reassured to treat the patients medically. What did I do? I did nothing. Now the question, the patient still has this non-obstructive lesion in their LAD. So we've still got this coronary artery calcium. So does the patient have coronary artery disease? The answer is yes. Would you add a statin to this patient? Yes or no, everybody? Who says yes? Who says no? So even though all of you said quite nicely, this patient doesn't have ischemia, or most of you said no ischemia, all of you are treating them medically, but you're all going to add the statin. So we're actually looking at two separate problems here. And quite nicely, this is statins the way to go. What about aspirin? Who's going to put the patient on aspirin? Yes? No? Come on, everybody's going to answer. You've only had 20%. Come on, commit yourself. Remember, the patient is on apixaban as well too. This is a clinical cardiological question. Aspirin, yes. Aspirin, no. And the no's have it. And the data for apixaban is quite good now. This is going to be a stable patient. Yes for statin, no for aspirin would be the answer as well. The patient was quite hypertensive as well too. Would you increase the dose of the verapamil, remembering that the test itself was done off verapamil? Who would increase the dose of the verapamil? Who says yes? Who says no? Who says don't know? And Prem says don't know, and I'm actually with Prem because, and I've written here, I wrote originally no, but then I put down not yet. So I'd put him back on the verapamil and see what happens to his blood pressure. Now, importantly, should I continue flecainide here? Who says yes? Who says no? Now, some hands are coming up here. Remembering that if this patient is on this class 1C antiarrhythmic, the chance of they're getting a serious arrhythmia increases in the presence of ischemia. And it's very common that we get asked by our electrophysiology colleagues, please do a nuclear test before we start flecainide. And they don't ask for a CTCA, they ask for a nuclear study because they're not interested so much in do they have CAD, they're answering do they have ischemia. And the question here is, some of us said mild ischemia, and if you said mild ischemia, you've got to say stop the flecainide. But João, you said no ischemia. So would you continue with the flecainide, yes or no? You'd continue with flecainide. The problem you have here, this man still has cardiac disease because we've shown diastolic dysfunction. He's probably going to have some LVH. You asked all the other guys for an echo. You should have asked me for one because I'd have showed you the LVH and puts this gentleman at markedly increased risk. So my answer is I would actually stop the flecainide and consider either amiodarone or do nothing, or if it comes to it, doing a PVI down the track. So in conclusion, what we actually have shown today, that adding the ETT to the imaging is always important. In this case, the patient achieved a high workload with no definite ischemia off verapamil, which guided me to medical therapy instead of a cath. For those of you that did say there was mild ischemia, you still were going towards medical therapy, importantly. Non-obstructive coronary artery disease has guided me towards a statin therapy, and we all agreed with this, aiming for a level of under 1.8. All of us agreed no aspirin, particularly in light of the apixaban as well too. We've shown diastolic dysfunction on this study, so if this patient presents with HFpEF, we've got ourselves an explanation for the shortness of breath, probably secondary to hypertensive heart disease. And we've guided our doctors to stop the flecainide. And sometimes, though, you could actually read the ETT and the images, but you read it wrong. So, João, I want you to read this next slide for me, please. That's Australian. That's Australian for you. So please, come visit me in Melbourne. We are the world's most livable city. And thank you again for inviting me.
First, I'd like to thank all the presenters for these marvelous cases and such a stunning presentation, e agradecer a participação do meu chairman, meu ídolo, Dr. ROMEU. Ele vai encerrar a sessão.
João, parabéns por tudo. Você realmente é muito mais que a gente imaginava. Você é grande.